we have a few more members joining in. We've gotten quite a few confirmations. I just pinged them, and they've invited their family members as well. So I just wanted to introduce everybody to Kanlade. We had met in Jodhpur in March on the 29th, and we had signed an MOU with the intention to work on Waldenstroms in India. So there are many steps in the process. Hi, Mr. Ganpati.
Hi.
Hi, how are you doing?
Sorry.
Are you
Sorry.
are you able to hear us?
एक मिनट
Request if you can. Yes,
Hello.
it's good to meet you, Mr. Ganpati. If you could just mute yourself, we'll get started.
No, you're not audible to me very much.
Okay.
Yeah. Now come to a place where I can listen to you. Tell me.
I was just saying it's good to meet you, and we're just getting started.
Oh yeah, sure. I will be on and on because I'm in a place where there's somebody else also, but I'm very keen that I listen to Hari Menon. He's my good friend.
Okay.
And thank you. Very nice meeting you after so many years. I mean,
Yes.
something or other keeps coming in, and I'm not able to do it. But yeah.
We're going to have this more frequently. So
Yes.
so as I was saying, we have a few members who are joining in. I've just pinged.
Sure. No worries. I can be. Only internet is a bit because I'm not at home, so that's the reason.
So to introduce all of you to Colonel there, and I met in Jodhpur on the 29th of March, and we signed an MOU. So some of you all might not know, but since starting the Indian affiliate in 2017, I have assumed a new role along with co-leading the affiliate with my mother. I have also been nominated to the board for the International WALDENSTROM's MACROGOBULINEMIA Foundation. And so we have signed a memorandum of understanding with Image in order to take forward our work on Waldenstroms. So this is the first of our meetings that we will have, and we will have more such meetings, and this will grow, and there will be more in the pipeline. So thank you very much for joining. We have a few more people we're expecting, but it's good to see. Hi, Kritika. It's good to see you.
There.
Hi, Prashant.
Hi, Saru. Hi, Rajni.
Hi, Prashant.
Yeah, Saurabh, please continue.
Yeah. So we will have more such meetings going ahead. Our goal is to essentially bring Waldenstroms to the forefront, not only for patients but also for healthcare providers and institutions in India, because there's a bridge that we have to right now divide in terms of knowledge in many aspects for Waldenstroms across the country for patients, caregivers, and also doctors. In terms of the current treatments and protocols, the IWMF is also planning to run a program where key doctors from important geographies like India, China, and Europe will be invited to get trained at Dana Farber, and then will go back to their home countries and be able to do what Dr. Treon did for Waldenstroms 10, 20 years ago. And so there's a lot that we hope to do now with Waldenstroms, and we've been at it for about 7 years. But it's a really important step for us to be able to collaborate, and it's really good to see Colonel Uday here. So as I was saying, Colonel Uday and I met in Jodhpur, and we're very determined to be able to support you all. Ultimately, the support group, the IWMF, whatever we're doing here, it's meant to be of service to you. And so this isn't a one-size-fits-all. If there are other things that you see in ways we can support you, other topics you would like to have for the meeting, then we can always do that. In the meantime, I'm glad to see there have been more members joining. And Konlada, if I've missed out anything, you can let me know. I'll just ping the rest of our members to see if they can join. We have close to 20 confirmations, and I've invited all our members. But yeah, it's good to have this meeting. And hi to everybody who's joined.
Okay. Thank you, Saurabh. Thanks a lot for that nice introduction and also updating about your role, which has evolved over a period of time. So, firstly, I'd like to thank all the members who have taken out time on a Sunday evening to come and join us. So, I'll briefly update why are we doing this and what's the purpose. So, primarily, like I'm a hemato-oncologist and I deal with all the blood cancers, and this happens to be one of the diseases which is a part of it. Now, over a period of time, we have realized that many of the particular subtypes of hematological malignancies or blood cancers are not appropriately addressed in the country. So there's a huge lag from the time the patient develop their symptoms to the time they get their therapy on. So our primary aim is to make sure that none of these individuals who are suffering from these rarer disorders or those disorders which are not very common to succumb to it or to develop long-term morbidities because of this. So as part of that, we have created a group known as Indian Myeloma Academic Group. And this group was created in way back in 2017. And I created it when I was at Delhi at Army Hospital Research and Referral. And thereafter, we worked for the last now 7 or 8 years now, wherein we have been expanding it gradually. So we have a national registry for all the plasma cell dyscrasias, and Waldenstrom's also happen to be a plasma cell dyscrasia. Now, slowly we thought that we, as part of expanding our wings or increasing our scope, we should not only concentrate on myeloma, we should concentrate on the sister disorders, and a few of them happens to be like amyloidosis or Waldenstrom's macroglobulinemia. And with that target, this year in January, we have started chapter in the society for Waldenstrom's. Now, what do we do as part of this society? So we have got three verticals. One vertical is for the doctors to keep them abreast with the latest knowledge, latest clinical trials, and to drive home multiple trials, because India is a place where previously around 5 years back, there were no clinical trials. Now in myeloma, thanks to the effort of the society, we have almost around 14 clinical trials going on. So for all those patients who were previously asked to go back home and go for a palliative care, now we are able to give them trials. Second vertical is for the students. That means those doctors who are evolving into hematologists or oncologists. So we try to train them and we try to improve their knowledge and to involve more and more hematologists and oncologists into the field of plasma cell dyscrasias. And the third vertical is a patient care vertical. Now, this is a very interesting or a important vertical, because when we started this myeloma group, not many patient groups were available, nor much was spoken about supportive care, caregivers, help, and other things. So we have created this to empower the patients in India, because I can understand all the people who have joined today's group. I can see that they are from the affluent society or they are from that part of the society wherein you people are able to take decisions. But if we look at the clientele within our country, 90% do not belong to this particular clientele, wherein most of them don't even know what are they suffering from. Even if they know what are they suffering from, they are not aware what treatment are they getting. Even if they are aware of what treatment they are getting, they are not very clear about that what is the prognosis, what is the way the disease is going to progress, the best selection method or the decision making. So these are not available. So as part of that particular process, we have thought that the keeping the Indian clientele or the Indian patient population in consideration, we need to have a set of guidelines, set of education material, set of IEC, which can empower them, first of all, to understand their disease, second, in decision making, and third, to close the gap between the patient and the doctor, because we understand most of these diseases we are talking about, it requires a tertiary care. And many of the people, we ourselves, when we sit in the tertiary care in an OPD of around 300, 400, it would not be possible to answer all the questions that the people have in their minds. So we thought that we need to have an informal arena wherein we can actually address the queries of the people and try to bust some of the myths and to reinforce some of the realities and to take that forward. So keeping that in mind, we created this third vertical of patient care, wherein we do a lot of activities as part of it. Now,
जगह बस एक ही बात चल रही है, बिना तेल के खाना बनाना। क्या ये पॉसिबल है? बोला जाता है तेल में कोई टेस्ट नहीं होता, मगर तब भी हम तेल का यूज करते हैं। लेकिन आज मैं इसमें टेस्ट करने वाली हूँ, क्या बिना तेल के हम
Thank you. Sorry about that.
No, that's perfectly okay. So the thing is, so as part of that, once we decided to have this Waldenstroms chapter as part of the Indian Myeloma Academy group, we want to extend the same thought process, what we were doing it for primarily myeloma patients, also for the Waldenstroms. And then we came across, we interacted with Saurabh, and he came forward, and we thought that it's good because the ultimate aim of the IWMF or the Indian chapter of IWMF and the image remains the same. We want to improve the quality of life of Waldenstrom's patient. We want to improve the not only the quality but also the quantity of life. So both quantity as well as quality. And we want to clear that or bridge that gap between the doctors and the patients in an informal way. So keeping that in mind, so we had this MOU of collaborating or having some common work between IWMF and Indian Myeloma Academic Group. So that's how we came together. Now, as part of this, we already from the image side, we have started off creating a registry, because for anything that we want to know, we need to know our statistics well. And statistics really is not meant for publishing or for getting some article or a paper out of it. But primarily, when we want to do advocacy, so if I put across this in an international forum or in a national forum in front of politicians or a decision-making body, the first question which will be asked is, what is your number? Whatever you are doing, how many are going to get benefited out of this? So we want to have our statistics clear. So for that, we have started creating a registry wherein we are collecting all the Waldenstrom's patients' basic information, just that to identify and map them on a map, that how many of them, where is the maximum concentration, so that we can put in our efforts in that particular area. So that's the first thing that we have done. Second thing that we are doing is to start off with this patient group meetings. We understand in the first few meetings, we might not have too many patients because it's a long-term process. We are not looking at a short-term, one-time event. So once we have this regularly, and if we are able to answer important queries or able to clarify few of the opinions of the people, it's a positive feedback mechanism. More and more people will join over a period of time. And as part of this, in Indian Myeloma Academy Group, we have got around 10 executive members who are who's who in the country. And we have also a panel of around 180 doctors with us. So we would like to rotate it over a period of time. And today, to participate in this particular event, we have the best of the oncologists from the Bangalore circles, who was ex-professor at Tata Memorial Hospital, Professor Harimenan sir. He actually does not require any formal introduction because sir has been teacher to many of us. He has been one of the best oncologists known in the country, and almost 60-70% of the young oncologists who are practicing between below 10 years of service would have been taught by him. So he's a great personality, and he has got a personal interest in Waldenstroms. He actually looked into this disease during his years and even continues to have that interest in this. So as part of this, we have requested Hari sir to come and answer a few of the queries today. After a introduction, so after this brief introduction, so once Saurabh starts, so the way we would like to have this patient group meetings over a period of time would be that Saurabh would be, I would request, in fact, Saurabh, to moderate the sessions wherein you can actually collect the questions beforehand itself. So there's nothing wrong if you circulate, like we circulate the next date of the next meeting on a given date, and the people can actually collate the questions. And these questions, if at all, if they are earlier, we can actually answer or write them down so that there is no communication gap. Because when we say something as doctors, patient picks up only a part of it, which he feels is important, which might not be the right message that we want to pass. To clarify that, we would like to have it in both versions, both in a verbal form, wherein we are as a dialect, wherein we are trying to answer them, and second, also in a written form. So we don't mind doing that. And over a period of time, these becomes FAQs for our Indian population, which can be published on the Indian Myeloma Academy Group website, wherein we can just say these are the FAQs and these are the answers. So that would help many more people. So we can do that exercise in a more formal form. That's first part of it. And second, the doctors or the experts who are going to rotate. So the questions can be posed to them and their opinions can be taken. We all understand, and every patient needs to understand who is in this particular meeting today, that the opinions might differ from person to person because there's no black and white as far as oncology management is concerned. The aim is, the ultimate aim for every oncologist remains the same. The quality and the quantity of the life of the patient should improve. But the way we approach that and the way we achieve that might be different depending upon the individual experiences. So that's the first disclaimer. Second disclaimer is that when people pose questions in this forum in the future as well, we would like to avoid personal questions saying that I had this treatment, this happened, and what happened next. Preferably, the question should be such which can help everybody who is attending the meeting, rather than just keeping it to one particular person. But at the same time, we don't say no to it. We like to answer in the best possible manner. But the purpose would be that every question and answer should help as many people who are attending the meeting as possible in improving their care. Third, we would also want to know from you that in which medium you want this session to be. Like, we are perfectly okay in having this in Hindi. All the experts of ours are equally good or better in Hindi as well. And also in any local lingos, if specific groups you want to have one for people from Kerala, we can actually arrange for people to advocate or to answer in Malayalam. Similarly, for those people who want in Kannada, in whichever language part of the country, we have got experts from every part of the country. So if you want a language specific discussions to take place, which is focusing on only one particular part of the country, we are okay to do that. We will be more than happy to do that as well. So that's also not a problem for us, but that's something which you need to give us a feedback about how you want it to go. So these are the few things which we want. And yeah, last thing, we should avoid in our discussions taking names, because for example, I should not say I got treated from Dr. A. Dr. A told me this, then Dr. B denied that or did not agree to it, and I went to doctor. We should avoid that, because the aim of these patient group meetings is primarily to make sure that all your anguishes, all your queries in your heart, which you could not talk anywhere, are clarified here. And at the end of the session, there's a mental peace and there's a hope which is there. The purpose is only and only that. So our aim is not, because we are a pure, thorough, a society with only and only people from currently working in government institutes or who have previously worked in government, with zero conflict of interest. So we are not doing this for any advertisement purpose or any pharma driven thing or anything. So this is purely to help patients, and that noble cause, if it has to remain, should avoid such things. So these are few ground rules or few disclaimers which I wanted to convey at the start of the meeting, because this is going to be the first meeting of ours. And based on this, we would like to build upon, and over a period of time, I definitely would like to see after a year and a half, that we have these meetings wherein we have got a lot of people, not only from India, but from the Southeast Asian countries coming and joining us. So our aim is to fill those gaps everywhere in the parts of the country, in the parts of the different parts of the world, wherein these facilities are not available, and to answer those people. So I will stop here, and I would like to welcome Hari Menon sir. Sir has been my mentor and teacher as well, and I revere him a lot. So I'm thankful for sir sparing his time on a Sunday evening. So I hand it over to you, Saurabh. So you take it on, and we are there for you. Okay. So wishing you all the best for all your future endeavors.
So just before I just sing, thank you, Uday. You're always kind in your words. Yeah. Happy to be here.
Thank you, sir.
Thank you, Colonel Uday. Hi, Dr. Hari. It's good to see you.
Hi, Saurabh. Hi, Saurabh. Yeah. Hi.
So this was an extremely, really wonderful introduction that Colonel Uday gave. I think when I was sitting with you in Jodhpur, I felt really inspired about the future for Waldenstroms in India. And, we've been, we knocked on a lot of doors for a long time. And it's really, really wonderful that we have your support and we can do this together. Thank you again for your time, because that's the most important thing. And for all the patients and caregivers who were able to join today, thank you again. Some of you all have been part of our earlier meetings. We had a few national meetings on Zoom a few years ago during the pandemic. and we plan to have larger meetings on Zoom going ahead. The goal eventually is, as Colonel Uday said, is to have a registry, and then once we do that, we can start seeing what the interactions of these medicines are, how people are doing, what the quality of life is in India. Because I was just at the education forum in Seattle that the IWF had organized, and all the references, all the patient data, all the studies right now are being conducted primarily in the US. And so all the protocols that we go by, they are, of course, based on those studies. And so the first goal for that would be a registry, and I would encourage you all to come together for that. And then also going ahead, we will have more such meetings, and we will then next year aim to have an in-person gathering, which would be really wonderful. Some of you all may have attended the Ed Forum that the IWF has organized over the years. This is their 25th year. When they started in the US in the 90s, they were a small organization and they had barely 20, 30, I think less than 100 people come. But our goal, as Colonel they said, is to grow this over a period of time. One thing that we've seen from our efforts as the Indian affiliate is that being consistent and staying here over a period of time really does the trick. So we will hopefully have these meetings grow, and we will have an in-person meeting next year, which will be really wonderful, and we will keep you posted. Some of you all had shown an interest in having a WhatsApp group. And I remember having these discussions with you all over a period of time. So I'll just send that invitation to everybody, and then we'll have a common forum where we can have patients who have Waldenstroms, who support people with Waldenstroms, and who treat people with Waldenstroms. And so we have Dr. Hari here, and we have Colonel Uday here. Again, thank you so much for giving us your valuable time. It's really an honor to have you speak to our patients. And so if there's any particular topic, Dr. Hari, you wanted to speak about, we could begin with that. But otherwise, we can, if you would like to have a Q&A, if some of our patients have questions, we could have it that way.
Yeah, that's fine. I think I will take it along in terms of if there is any explanations that are required as part of the question answer. I'll just take it along at that time rather than have an introductory thing. Yeah.
So I would like to maybe get the ball rolling in that case. So one really hot topic at the Ed Forum at Seattle was treatment options, and there's always been a debate for bendamustine rituximab and or maybe going for BTK inhibitor. There's been a lot of debate on both sides. And for us, for example, Mami is going through bendamustine rituximab right now. But did you have any opinion or any thoughts on that from an Indian context or from your experience of treating patients with Waldenstroms?
So the use of the targeted therapy or the Bruton tyrosine kinase inhibitor, or what we call as BTK inhibitors, have been a more recent development. And you say recent development probably in the last less than a decade. Yeah. And we have always known that Waldenstrom is not a disease that is curable. And at the same time, its treatment options range from watchful waiting to more intensive therapy, to chemoimmunotherapy, and more recently the use of targeted therapies. So when we have such a scenario, we always like to pick and choose the kind of treatment we want to offer. So if you look at it, when a patient requires treatment for Waldenstrom, and when it comes to that point, we know that chemotherapy works, immunotherapy, or I wouldn't say immunotherapy, using monoclonal antibodies work. And we have robust data to support the use of these agents with a predictable response rate in these patients. So under those circumstances, we are more comfortable in exercising our options in a judicious way, and sequencing our therapies also in a more judicious way, wherein we have options available down the line for a disease that is known to have a relapsing, remitting course over here. So, if you ask me if a patient does require treatment, my first choice would be to look at chemotherapy along with immunotherapy, along with the monoclonal antibody, because I don't see any reason, come whatever the data, except for the fact of convenience of treatment, wherein the patient just needs to take in a pill. We are quite comfortable in recommending chemoimmunotherapy for such patients. Yeah.
Thank you, Doctor. I had a follow-up to that question, which was sometimes we've noticed, at least in the studies in the US and abroad, where these treatments can sometimes have adverse events, or they can have side effects in themselves. So one side effect that people have seen is a neuropathy after having started treatment. But are there any special or very rare side effects you've seen for Waldenstrom's in your time treating it in India?
So one of the problems in Waldenstrom is, of course, bone marrow suppression, and sometimes with any treatment, and anemia becomes, and one of the manifestations is anemia, not so much leukopenia or a drop in WBC counts or a drop in platelet counts, is anemia. And we know that, for example, when we treat, you can have aggravation of anemia when we treat with chemotherapy, but they are all transient. And once the disease comes under some sort of a check, that aspect also goes into, it becomes well controlled. Now, your question about peripheral neuropathy, many a time we attribute the manifestation of the chemotherapy to the treatment that we give, when we know that all plasma cell dyscrasias, which includes Waldenstrom, although Waldenstrom is got a gray area of being put under the category of a low-grade lymphoma as against a plasma cell dyscrasia. But having said that, it originates from the plasma cells, and so neuropathy is part and parcel of the manifestation of the disease, and those neuropathies are not actually completely reversible, but it can get aggravated with the use of the drugs that we use. With the drugs that we use for Waldenstrom. So when we are using, in the past, when we're using drugs such as melphalan, or for that matter, fludarabine, etc., which we don't use these days, it used to be a little bit more, but not so much when we used drugs such as bendamustine when we are treating Waldenstrom macroglobulinemia. So I don't think it is so much of a concern. But then if a patient is having some sense of some degree of neuropathy, then we have to follow them up more carefully to try and understand whether your treatment that we are administering is aggravating a pre-existing neuropathy. That's what we need to look at.
Thank you. So one thing that I had come across was we had one of the chief doctors at the Fred Hutchinson Cancer Center at Seattle, which is one of their research hospitals in the US, speak about how they were trying to find a cure for Waldenstrom's. And one way they were trying to do it by was to maybe try CAR T therapy. What did you think about that? Because we spoke about this in Jodhpur as well. There was a recent article about, I think, one of the IIT centers coming up with quite inexpensive homegrown CAR T therapy. But just your thoughts maybe along CAR T therapy.
Currently, CAR T cell therapies is basically exploiting your immune cells to do the job that is concerned by allowing it to target a specific receptor, which will trigger an immune-mediated response to kill the tumor cell. And we know that the general hypothesis and the understanding is that for any lymphoma, or for that matter, any hematological malignancy, is that it is a stem cell disorder. Yeah, it is. There are what are known as leukemic stem cells or lymphoma stem cells from which the disease actually emerge, and those stem cells can never be eradicated through conventional treatment. Sometimes you can, in some of the more recent medications, such as BCL2 inhibitors, seem to have some impact, but overall it doesn't have an impact. And we don't know whether CAR T cells also can do that job, actually. The reason for relapses in most of the lymphomas and leukemias are because of the inability to eradicate these stem cells. So if you can eradicate the stem cells, which is potentially potentially possible with a cellular kind of a therapy, of which CAR T cell is one of them, we may be able to look at. So it is speculative over here. We don't know. And only time will tell us whether we can actually, cure conditions such as Waldenstrom macroglobulinemia. But my feeling is that it may not be the case, because we still encounter relapses in patients who undergo CAR T cell therapy for other indications. And I think it is in its infancy, and it will be premature for us to predict that doing CAR T cells is giving CAR T cell therapy is going to eradicate or cure Waldenstrom. Why would you, in the first place, use CAR T cell therapy for a condition that can be well controlled? Yes, maybe 90% of them, or probably 85, 86% of them, are indolent diseases, and you can actually live with it without having to intervene in a very significant way. And what people don't talk about are the problems that one have to deal with after CAR T cell therapy. It's a wonderful therapy. It's one of the novel treatments that have come into the armamentarium of treating lymphomas and leukemias, especially B cells, not any others. And Waldenstrom is a B cell lymphoma, so there is a potential for using it, but I think it's a long way away. And I don't think it is going to be exceptional for us to be using CAR T cell therapy to treat Waldenstroms, actually.
Thank you. I was thinking about what you just said, in that Waldenstroms is an indolent disease, and many people often, their quality of life is quite great. Something that I sort of harken back to the Ed Forum again. So when they started the first session, I think Carl Harrington, or the chair of the board, I think Pete Donatis, he asked everybody with 5 years of Waldenstroms to stand up. So he made everybody stand up, and then he made everybody with 5 years of Waldenstroms sit down, and then 10 years, and then 15 years, and 20, and then we got to 30 years, people who have Waldenstroms who were still standing. And so that was really, really, really wonderful to see. And my question would be that sometimes we noticed with some of our members that they did have a frontline treatment. In most cases for them, it was bendamustine rituximab. But then they either, we aren't really sure, it's all conjecture at this point, but they had to, after COVID, get treatment again. It could have been the disease itself. And some of them then chose to go for BTK inhibitors the second time around. So in the rare case of, in the case that someone would maybe have to go get treated again, what have you seen in your experience? What have patients taken? What would you recommend? Would you recommend that they take BNR, or would you recommend they take BTK inhibitors? Or
it would not be inappropriate, I would say, to re-challenge with the same chemoimmunotherapy, provided there has been a reasonable time gap between the first and the second therapy, and you still have responses over there, but it may not be as durable as what you get in the first time around. But having said that, suppose a patient has tolerated the first time around very well and has had a reasonable time to disease progression, then we could use the same drug again to use for in Waldenstrom. But we are talking about an era where we are now having BTK inhibitors quite easily, and with the availability of BTK inhibitors at reasonably priced because of the generics that are available right now. And from that perspective, with the data that is available, there is really no reason why we should not adopt using a BTK inhibitor in the second line setting, and both from the convenience of dosing and the convenience of taking the drug, and also the friendly side effect profile that are few and far in between for such patients. So currently, if a patient comes with a relapse or a progression, I will say that I might be inclined to be putting them on a BTK inhibitor rather than re-challenging them with chemotherapy. Uday, do you have any views on that? Yeah.
Yes, more or less, I agree with whatever you have said, sir. Just to make it more objective, those statements. So we will see if the remission state has been there for at least 3 years following a bendamustine rituximab therapy. Then most of us would like to re-challenge it with the same chemoimmunotherapy, as Hari sir said. And for those people who have had it for less than 3 years, BTK inhibitors would be a good option. But again, it always does not fit in the same picture, because the ideal therapy in such situation is zanubrutinib, and the availability of that in our country is a problem. Ibrutinib or acalabrutinib on today's date, with the newer studies which have come in, have not really shown so much of benefit in long-term studies. So considering that, when we say that are we planning for BTK inhibitors, so the answer is ideally yes, but do we have the availability of the ideal choice of drug? Is no. And then, is it better to get them back to BR even for less than 3 years versus putting them on a drug which is not the ideal BTK agent in a relapse setting? So these all needs to be weighed. And also the other factors which Sir brought out, like people who have had prolonged cytopenias following bendamustine rituximab, or having some vague side effects which are very patient specific. So in such situations, then we look for alternatives. And alternatives obviously are BTK inhibitors. But I more or less agree with whatever Sir said. So I echo his understanding or his comments.
Kavanda, you actually, I was just thinking about that. Many times in India, in a patient setting, we're recommended acalabrutinib or ibrutinib. And as you said, zanubrutinib is not easily available. And the site, for example, for my mother, they had first, for mommy, they had first recommended acalabrutinib. And we saw the sort of the side effect profile of that. We really wanted zanubrutinib, but hopefully it's a matter of time before we can get genetics and it is more easily available. Because something that, was really fascinating is when I was speaking to patients in the US and trying to understand how the healthcare system worked. All of them get their drugs through insurance, of course. And when they started hearing what the cost of generic medicine was in India and how easily it was available and how effective it was, that's something that really blew their mind. And so I hope that we're able to get zanubrutinib more easily going ahead. My last question before I throw it open.
Just to add to the point is that it's not like as if that acalabrutinib is not a good drug, or it has no, it's not a thing. It is basically to do with some of the mutational landscape that some of the people harbor, and if they have a specific kind of a mutational this thing, it doesn't work over there. But somehow zanubrutinib has able to overcome that and is effective over there. That's the reason.
Yeah, just to extend what Hari sir said. So previously, when ibrutinib came in, so in 2015, 16, and 17, we had put quite a number of patients on ibrutinib as well. Patients were on only BTK ibrutinib. Patients were on ibrutinib with rituximab. So it's not that if a study does not show numerical value dominance or a superiority or some p-value not being perfectly okay, that drug should be eliminated from the market. It does not work so. So the whole art of managing oncology or hemato-oncology patients is all about identifying what suits best the given patient who is sitting across the table. And that's a pure art. So a patient who, like as you gave the example during the COVID era, where we could not get the people to the hospital to get their rituximab maintenance or to give them bendamustine, and we were all relying on oral agents. So during that time, zanubrutinib was not even spoken about in the world, and we were all relying only purely and purely in India on ibrutinib. And patients did well. Patients did hang on during that period. So yes, those patients who have some side effects, who have some atrial fibrillations because of that, some patients where the values of IgM are not reducing, patients are persisting to have symptoms or worsening of symptoms is all okay. But it's just not that just based on one study, we definitely say, yes, this is the best drug. And based on one study, we totally eliminate it from the market. It doesn't happen that way as far as the clinical practice is concerned. Now, in US versus India, what happens is most of the people who follow these guidelines or these studies, the major problem in US is, as you just briefly mentioned, is all insurance based. The insurance only covers if there are studies to prove it, yes or no. Whereas in India, we have a slight liberty of going away or giving what is known as offline therapies or metronomic therapies or some patch-up therapies wherein a patient, because of socioeconomic reasons or because of his various other conditions put into picture, we might modulate the treatment. Now in US, because they have withdrawn ibrutinib, the license and the FDA license for that, they just cannot give it anymore. They have to perforce give them January, otherwise they will not get the insurance coverage. Whereas one study cannot eliminate it from market. At the same time, the number of studies for janibrutinib you see aren't huge. Maybe 5 years down the line, it might go the same way as that of it. But yes, definitely, these new drugs have brought in new understanding of the pathophysiology. And what Harisa was saying, there are certain mutations which we are aware of now, which shows that this particular mutation, this particular drug works better, which that particular understanding was not there 7 or 8 years back. So we are slightly more wiser, and these mutations are happening in India currently. So we might upfront choose our patients for particular group, treatment groups based on this landscape, genomic landscape that we have.
Thank you very much. I have one final question before I open it up to all of you all. So what did you all think of, say, bone marrow transplants as an alternative or last resort for patients who have had Waldenstroms? Because in our support group, many years ago, we had someone who did have a bone marrow transplant. And it is something that has been discussed in the affiliate as well. What are your thoughts in terms of the risk profile for doing something like that versus the benefits of completing that?
Yeah, so most of the time, Waldenström macroglobulinemia is a disease of the older age group and above the age of 60 or maybe even above the age of 70. And doing transplants, while it is theoretically possible for us to do transplants in these patients, we know that doing something like an autologous stem cell transplant is unlikely to bring about a significant benefit over and above what we do with chemoimmunotherapy, especially in Waldenström macroglobulinemia. And so generally, while it can be done, it is not something that is routinely practiced for treating Waldenström macroglobulinemia. Secondly, if you want to have an objective of trying to cure the disease, then one has to think about using something like an allogenic stem cell transplant. And doing an allogenic stem cell transplant for a condition which is categorized as a lymphoma it used to be done, but it is no longer considered one of the indications up there for doing an allogeneic stem cell transplant, so we don't do it. And now with the advent of CAR T cells, perhaps one would look at that as an option rather than doing something like an allo transplant, if at all it is being considered, because in effect, it's a cellular therapy, and perhaps CAR T cell, though it is an autologous CAR T cell that we do use, if at all we use that, it will do the job that an allo transplant will do. So the biggest roadblock would be that older patients, and it is that the transplant related morbidity and mortality is far outweighs the benefits of doing such a procedure in these individuals. So I would say no. Yeah, I would say no. Yeah.
Thank you, Doctor. So I have two questions that have been sent to me from somebody who was on the call but was in transit, which I can ask. But I would like to open it up to everybody else if you have any questions. Dr. Kritika, actually, I also got this question from someone who is in the same age range as your friend. So the question was submitted to me on bone marrow transplants by a young patient who had bendamustine rituximab therapy a couple of years ago. He is the same age as I am. I'm 36. And so he was wondering, as someone who's a young WMer, what he should do for the transplant. So thank you for that. But if you all have any questions, it would be wonderful to be able to ask the doctors present. So we have one in the chat right now. How is the efficacy of ibrutinib for relapsed patients?
I think we did answer that question. Probably he was there
Yes.
at the time. So the thing is, we can use it, but as we had discussed before, we need to look at I mean, if you want to be discerning about the way that we want to use it, then we would probably want to look at the mutational landscape over there and then determine whether it is really going to be worth using it. And in that situation, we can use ibrutinib, all right. But now with the current availability of acalabrutinib, maybe acalabrutinib would be the one that we use in such patients. And of course, if we have to move towards using an BTK inhibitor, then one hopefully will look at using zanubrutinib, but if it is available in the future. Currently, it is not in India. Yeah, but I think acalabrutinib is what we would consider rather than ibrutinib over here.
Thank you. So I'm cognizant that we have about 7 minutes for our session. If anybody has any questions.
Good evening, sir. I'm Dr. Kritika. A friend of mine has been diagnosed with WM at the age of 27. So I just wanted to know, how has your experience been regarding treating patients with WM? Currently, he's undergoing treatment here at R&R in Delhi. So I just wanted to know, because the data is far and few regarding the young WMers, and as to how much can we extrapolate the data, which is usually with the adult patient, I mean the elderly population. Can we actually extrapolate the data to the young ones, and how has your experience been so far?
Yeah, honestly, I don't think I have any experience with treating young patients with Waldenstrom. I would certainly look at excuse me. I would certainly look at trying to really think whether this is an Waldenstrom macroglobulinemia or whether it is some sort of a high-risk myeloma, like an IgM myeloma, which is also an entity over here, which needs to be really looked at carefully, because I'm yet to come across anybody so young with a Waldenstrom macroglobulinemia. But I wouldn't treat it any differently. But then what we have discussed in the past, we have to keep the options of in the future for probably treating this like a multiple myeloma kind of a treatment over here, maybe look at and even consider doing an autologous stem cell transplant in this particular case over here, provided he doesn't have any comorbidities. But all these are individualized. It is not something that we have data upon. But certainly, one thing that I would certainly consider is whether this is really, by definition, truly an a Waldenstrom, as against being an IgM type of a myeloma. What do you say, Uday?
Sir, I totally agree with you. In fact, my first question was that were the mutations done in this patient, and when you are saying he is balanced off, so probably you might have already got it done. But otherwise, it's important to get the mutations done because around 5-7 years back, we used to most of the times diagnose Waldenstrom's only based on morphology and IgM protein. We were not routinely doing CXCRs and the mutation panel during those days. How frequently we are doing nowadays? So first is to reconfirm the diagnosis. Now, what Sir said, transplant is definitely an option in such patients because transplant, when Saurabh asked the question of role of transplant, in the current era, the only role of transplant is in young Wallenstroms. So that's the only place where it helps the most. And otherwise, the drug profile or the chemoimmunotherapy or the BTK inhibitors therapy is so good that most of the elderly patients, they don't require transplant or their performance status is not good enough to tolerate a transplant, wherein the risk versus benefit ratio does not weigh in favor of the patient. So considering that we don't do transplant, so this is the ideal patient who should be considered for transplant once the diagnosis is confirmed with autologous as far as that. And definitely such patients are those who can be kept in mind for taking up for trials whenever we have the new trials coming up in the country or whatever it is, either the new drugs or the CAR-Ts or something of that sort. So they can be taken. But yeah, our experience with at RR only, our experience with young Wallenstroms has never been very good. We have almost around 7 or 8 patients who are below 40 or 35 years of age. So generally, young Wallenstroms really do not tolerate disease as well as the older patients. I really am not aware why so, but they come up very frequently with complaints, with various symptoms, with various problems, and with the M spikes or the IgM levels shooting up very frequently. So somehow their disease is more fragile when compared to the older patients. That's just a small experience of just 5 to 6 patients that we had there. I cannot extrapolate it for younger Waldenstrom, but our experience was not good with the younger patients.
Thank you so much, sir.
We have 2 more questions if we have time. So I'll just take them together and doctors, you all could answer them. So the first question is by Amrita. She asks, hemoglobin is low despite treating with bendamustine. What could be the reason for that? And the second question is by Gaurav. He says that after 6 bendamustine rituximab treatments, is there any impact on overall remission without maintenance therapy? And how should one proceed with blood tests and PET scans after achieving good remission?
Yeah, so one has to look at, generally it is not a feature of continued chemotherapy-induced bone marrow suppression as far as bendamustine is concerned. You may have it for probably, first of all, it is rare for us to find significant bone marrow suppression with bendamustine, although the problem that we encounter with bendamustine is more about infections down the line and increased incidence of infection using bendamustine, but not so much. So one has to look at what the reason for anemia is. Is there something, because all these low-grade lymphomas can have some sort of a low-grade hemolytic anemia kind of a picture, and one needs to see whether there is some increased destruction of the red blood cells that is happening, which is causing the anemia over here, or whether there is something nutritional. And if it is persisting, it may be a good idea to look into the bone marrow once again to see whether whether there is some sort of suppression of the bone marrow, I mean, red blood series to causing this, or whether it is because of any residual disease that is present in the marrow. So these things are, so one has to actively investigate, but I would think that doing that should be after giving it some reasonable amount of time, rather than rush into something like that immediately to see what might be the case. But one has to do the routine tests that one does to investigate an anemia, and look at the possible, starting from nutritional causes to some sort of a bone marrow suppression to hemolysis, which may be some of the causes over here. And the second question, I'm sorry,
I'll just put it on our chat.
Yeah.
It would be. I'll put it so everybody can see.
Yeah. Okay. So. Generally, we don't give. First of all, if you are using a bendamustine backbone, as this is true for any low-grade lymphomas, even though there is some data coming up for maintenance after bendamustine, it is not something that is resorted to with Waldenstrom or after bendamustine rituximab chemotherapy that's been given. So we don't generally give maintenance rituximab in such patients. So in a nutshell, that is what we advise. No maintenance, as is true for any low-grade lymphoma. So we don't give maintenance therapy. PET scans, etc., has very limited value in Waldenstrom macroglobulinemia, unless, of course, as part of the low-grade lymphoma protocol, they're manifesting with a lot of lymph nodes to start with, and it was done and it was documented that they were lymphadenopathy. Otherwise, PET scan is not a modality of investigations that is favored in Waldenstrom. I'm not saying that you cannot do it, but it is certainly not something that you will do on follow-up as a follow-up PET scan evaluation. Because generally what we is go by the symptomatology and also the biochemical parameters that might yield some indication of disease activity. So generally we don't do PET scans. I mean, it's not a recommendation. You might do it in a particular individual, but it is not a routine to do PET scans.
Well, thank you, Doctor. So we have Rajat, who just joined. Rajat was part of the Indian Foreign Service and one of our biggest supporters, and still is one of our biggest supporters when we started the affiliate in 2017. It's good to see you, Rajat. We met at our last support group meeting in Kolkata pre-pandemic in February 2020. So I think this is the last question before we close things. I want to be really mindful of Dr. Hari and Kolkata's time. And it's a small question if time permits. It is, does ibrutinib trigger bradycardia? I'm sorry if I have not pronounced that correctly.
Uday, you want to take that or?
Yeah, yes, sure, sir. So ibrutinib can lead to any sort of arrhythmias. So it can lead to atrial fibrillations, it can lead to tachyarrhythmias or bradyarrhythmias. So rarely, though tachyarrhythmias, that means the increase in pulse rates are more common when compared to fall in pulse rates, but it is known that ibrutinib can lead to bradycardias.
Especially if you are also on any other antihypertensive drugs, such as a beta blocker, one has to consider that also in the larger picture.
Thank you, Dr. Thank you, Colonel. So I think with that, we would like to really, really sincerely thank you very, very much for your time and for the love that you're giving to our patients and caregivers and our community. We are really, really appreciative that you could come here and speak to us, and we're really glad that we can have these meetings with you. And on behalf of all of our patients and our members, I would like to thank you all very much.
Thank you. It is our pleasure. Yeah, thank you.
Thank you.
Thank you. Thank you.
So thank you, everybody. We will have more such meetings. I will keep you all posted. We will create a WhatsApp group by popular vote, and appreciate all your time. And if you would like to say anything there, Dr. Hari, we can. Otherwise, we can.
Over to Hari, sir. So anything from your side?
So nothing really, but it's just that when I was doing my post graduation in oncology, they were few and far in between. I still remember when I was doing, I saw one patient during my entire DM program at AIMS, whom I distinctly remember. And that at that time, rituximab was something that was not so easily compared. We gave him rituximab at that time, and with fludarabine, and that he had. But now, with the awareness that is happening, and also the diagnostic capabilities that have improved significantly, and also many a time people going in for routine tests as part of their company program or health checkups, etc., we are coming across a significant number of patients who may be having Waldenstrom macroglobulinemia, but one needs to also understand that there is a distinct entity known as IgM monoclonal gammopathy of unknown significance, and that should not be mistaken for a Waldenstrom macroglobulinemia. And these are some of the discerning things that one needs to keep in mind. You have to be discerning about the thing, and it is not something that we need to be really worried about. And more importantly, whenever I talk to any of my students and trainees, I just say that it's more difficult for us to counsel a patient not to do anything than to actually treat the patient. So exercising patience and not treating a patient is one of the biggest challenges, I think, we as treating doctors sometimes. The difficulty in convincing the patient that don't have to do anything and just wait and watch is probably one of the difficult things. Yeah.
Those are really wise words. It's something that we experienced with Mummy. She was asymptomatic for 13 years. And every year when we would do the scans, we would be encouraged to start treatment. And then in her 14th year, we started treatment. But there was a lot of pressure to start treatment. And then I think our doctors were very wise in that they said, no, you have no symptoms and you should maybe wait for some time.
Yeah.
So with that, thank you very much, Dr. Hari.
Thank you.
It's a real pleasure and a real honor.
Thank you.
Thank you for your time.
Thank you. Thank you. Good evening.
Thank you all. Good night.
Thank you very much.
Bye, Uday.
Bye-bye. Thank you.
Good night, sir.
Good night.